So we had 9 months to really do what a year required us to do. So what I'll show you with some of the slides too is, it's a transformation, it's a journey. So what we did was, well, let's learn how to do this well. You know, so if we don't do well on the share savings part, the first year, that's okay, because if I don't have my quality metrics together, we're not gonna be able to do a lot of these things. And I'll kind of instruct, you know, show you a little bit of what we did. This is a little bit of the format that I'll follow. There's an accountable care atlas, and they did this pretty good. And I think this is a nice flow sheet, because it tells you exactly where you start, what you have to put together, and the areas that you'll have to focus on. And really important are care delivery and health IT. Those are two areas that you eventually have to build as you mature. So what we did with our flow chart was, we took a beginning, intermediate, and put it together in that first year in terms of the things we did, so that by year 2, we were ready for a value-based level 2. So this right here is a commitment. We had to make sure everyone around the table knew that this is what we wanted to do. And when you put enough doctors in one room, it could be a problem. You know, I mean, everybody comes up with their way of doing things, and then we have specialists in the room, and then we have hospitals in the room, and forget it. Then it really got a little interesting. The other side is the education that took place. And I think what it did was, it opened a transparency among doctors, where we're trying to not kind of, you know, hide from each other, but really see each other's data and figure out how we help each other get through this process. The other side of it is really, the analytic platform is key. Without that, it's really tough to do this. So, you know, other individuals have depended on insurance companies to provide you data. They don't have all the data, and I'll show you what we were able to kind of accomplish as a result of that. And I think the other thing is just the reporting. How do you get that information back at different levels? And so we put together a value-based team that's made of different individuals. We have a champion, doctor, and that team kind of reaches out to each of our sub-teams, because we're dealing with a hospital system that has their clinics. Their problem is their informatics. Everybody's Cerna and Epic, knowing that Cerna and Epic are Cerna and Epic. They're just in their own space. And when you're trying to compete in this new model, you're not gonna do fairly well. What I found is that the primary care physicians, the ones that are in groups, the ones that are in private practice, those are the guys that I wanna work with. They understand it. They got more of their systems, and they're willing to learn. The ones in hospital structures, unfortunately, when you're paid by salary, you tend to forget, and it's not the same, you know? So I like hunters. I always said, I want hunters in my team. They work better. So when we perceived this, we started out the first year, which was 2017, with a value-based level 1. And as you know, that's upside only. What we did was, we defined, and I'll show you what we defined in terms of the contract. So I made the contract to be as sweet as for us, not the insurance company. So I picked my 15 measures. I picked my core scores. I looked what Medicaid rates were, and we went up a little higher. So we made sure that we were gonna hit our quality metrics. But now I had to get everyone on the same team to learn that. And that's difficult, especially when some of them don't even know how this stuff is being recorded or where the data is coming from. So that was one thing. The goals, as you know, was to really maintain that cost, hit those quality metrics. And this right here became to maximize that risk stratification. What we found as we go on is that risk scores among hospital structures are low. They're like 1.2, 1.1. Coding is terrible. They're not coding correctly. So then in the primary care offices, our private practice, we're risk scores at 3.54. And that right now is one of the issues that we run into value-based, because it's sort of like when you start up a practice, you need 3 to 4 months to kind of have cash flow coming in, cash flow coming out to stabilize an office or any business. In these models, what happens is that risk acuity in terms of costs and dollars, you don't see it. So with the contract that we got, was everything was sort of attached to a 2017 actuary. And that's how they were managing our dollars now. So in the first year, it's kind of difficult. Number 2 was that they designed a model where managed care had already contracted with hospitals and everyone for dollars. And now you want me to play that game. So we don't get the rebates on pharmacy side. You know, I don't know what your cost was for beds. I don't know what your cost was for ER. And I have to learn all that in the first year. So what we decided to do is, let's go smarter. Let's try to just get our IT informatics. Let's get our care coordination together. Let's get everybody to start kind of developing workflows within our system. so that we can actually improve on this area. So as you can tell from share savings account, it's, you're getting a total global budget, and then you're deciding the dollars that get spent, and then from there you get a differential. And I'll show you the buckets, because as you start to look at data, you learn so much from it. And you learn a whole lot of things. It's sad, but in a value-based agreement, you're matching up an adult to a child. In the healthcare system, as doctors, we're children, because we don't understand the power of data that they have. So it's hard to kind of negotiate, but you learn pretty quick. I mean, we went to medical school, so we do learn pretty quick. These were the areas that we decided to go after in terms of evidence-based metrics. And there we're focused on primary care screenings, and chronic diseases. And we figure if we hit these targets well, which is what we do in medicine, we can actually come up with good results. So what we did was, I know the state wanted 30 measures, 35 measures. We get them the data in terms of reportable data. But for our contract, if I hit 12, I get 100% of that 50%. Pretty simple. And I made sure that before we started this, the data showed that I already had them. So I didn't want to come into this game and not understand. So I picked the quality metrics, so now we can start to talk what's important. As part of the pilot, the nice thing about the pilot was that there were some dollars allocated to this. So now, who gets those dollars? So one of the things they did is, because they adjusted it to 2015 on our balance, it ended up being 10,000 lives because we were able to bring in these other players, but this is the number we started with. There was an allocation of performance adjustments of $938,000, of which we got 75% of that, and managed care got 25%. Then for reporting our data, we get $156,000. So in the first year, it's actually not too bad to begin with. You're getting some dollars, building in your infrastructure, and so let's focus more on the quality metrics, and we're gonna take it from there. The second year, as you can tell, you got the same allocation, but this time we keep 100% of that. And we also get, because we're a value-based level 2 this year, we get an incentive of $156,000. And so, you're getting $1.2 million to start off the floor, which is good. That's what you want when you start it. And these pilots were actually really good as a result of that. What we took our dollars to do was, so how do I get these doctors to come in, right? They're busy. They're doing a lot of good stuff. So we incentivized $5 PMPM. And that would include you coming in for some course training on billing. If your coding's terrible, that would be part of committees. That's coming into meetings, but that's engagement. So if we see those engagements and you're showing up, you're getting a $5 PMPM. On the 10,000 lives, if you do the calculation, we're talking about $600,000. That goes back to my people without anything. We haven't really done anything. So it kind of stimulates them to kind of look that this is not a bad model. Insurance companies had to spend their dollars a little bit different. What they got, the legal, the actuary. And I think when we did the contracting, one of the things that we looked at was, so I had my COO, CFO, CMO, CEO on my side, and they had theirs on their side. And so we started to kind of go back and forth. And for the pilots that were involved, the value-based pilots of these insurance companies, the one thing is they get immunity in terms of having the 80 to 90% value-based threshold. If they were part of the pilot, they get a little more time. Most people are going to have to kind of get there by 2019. These guys are going to get a little more time because they were engaged in these types of pilots, as we described. So what we did was, it's a negotiation. So the medical loss ratio, we decided to make it 89. We put a target on it. And then we also, like I told you, kept 75% of the dollars that came in through the pilot. In addition to that, we talked about the $5 PMPM that we're going to give the providers. And it would be a 50% surplus, with no downside. In addition, 1%. So we get a care and management fee of 1%, which ended up being $275,000. We capped it at that. So these are dollars that are coming in the first year that we did this. The problem with the agreement is not only the acuity scores, but there's a delay in data, 30 to 60 days. Now they've got great claims data, but there's also gaps in their data. Gaps in that no managed care in the system records blood pressure at all. So none of you guys report or do blood pressures in your practices in terms of the data they get. And so we had those kind of gaps. So if blood pressure is one of my measures and you don't have, how do I get that data back to you? And I'm also dealing with a hospital, and I'm dealing with clinics that don't have the informatics to get this information back to me. So we had to play with that. The second year, what we did was, same MLR, we went with 100% of the DOH adjustment, that's what we wanted. But now, if I'm at risk, I want 60%. We ain't doing 50% this year. I want 60%, you get 40%. At the same time, I got a cap at $500,000. But remember, I talked to you about that $5 PM that added up to $600,000? So I backloaded this. I'm covered, even if we have a bad time. Nobody gets their PM, $5. But at the end of the contract, it's not bad, but we also get a care management fee for that area. So this contract wasn't bad for us in terms of how we've been kind of waiting. And we finished 2017, but we're still getting backload data, and we're going into HEDIS and all this stuff that we're trying to still push in, that we're trying to make work. And I tell you why. So our informatics are really good in terms of aggregating, but Cerner connections are really a nightmare. And when we try to get the connections, the hospitals don't even know what to connect. So what we did was we worked around that area and went to the reals. So since the reals are getting some hospital data, and I can scrape, hemoglobin A1C, I can scrape stuff off. I don't know if you know, but hospitals, when they transmit their bill, it's a global fee. So if they did microalbumins and hemoglobin A1Cs, that stuff doesn't get billed. So there's no claims data on it. But through the reel, I could scrape it, and then I could find out which of the doctors, and we got the permissions to do that, we were able to aggregate some of that data and help on some of the quality metrics we were missing. So even though they didn't get them in the office, we were able to get them through the hospital structure. So that worked out pretty well. The one thing in the contract for value-based 2 was, and I talked about it at the pilots, was, we're dealing with different markets when you're dealing with accountable care contracts. Commercial is different. Commercial it's much easier in terms of the finances. Medicare is not too bad, but Medicaid, you got a problem. And if you don't work on social determinants of health, you're not going to be able to solve this. Simple things change things. So the one thing that we focus on was CBOs. Now in the beginning of the process, the health homes created a GRUM. We created the Greater Buffalo United Ministries. So we put all churches together. A lot of food pantries, they work with that. Other CBOs in the area were also organized to kind of do that from the health home side. And that's how we're incorporating them here. The social determinants of health that we picked was transportation. So the health home, which is unrelated to the ACO, had purchased 6 vans. And we picked people up and dropped them off where they needed to go. So that worked out pretty well. Now, come May or June of this year, we're actually going to become a Medicaid transport service for Erie County. And what that'll allow me to do is to really redirect a lot of the flow. So I can have a navigator from our care coordinator on call through our call system, and when that patient calls, we can redirect them to after hours, away from emergency rooms, away from ERs. That just doesn't happen. And so we start to kind of get more creative and make primary care kind of, we pay them for that, and we're getting into telehealth, telemedicine, all as part of the same contract, because we're going to find that social determinants of health, besides transportation, getting into housing, getting into some of these things, can actually affect your costs, and we saw that. So we were actually featured by the Medicaid director, because he called us and said, well, I saw that you guys were working with Lyft. I said, yeah, we're working on Lyft, and this is the pilot that we put together in terms of using Lyft as overflow. So if we found that we couldn't handle that population, now that we're getting to the Medicaid market, we may take on a bigger piece. We have 80 health navigators right now, and every navigator carries anywhere from 80 to 100 people. So it's concierge service. That stuff works. And what we do here is they can also transport these individuals to their sites to make sure they get their medicines, especially the ones that are the high risk. So we have that sweet spot, a sweet spot of 20% of these people that if you don't manage well, they end up everywhere. But if you put a concierge person on their side, you control utilization quite a bit. And you notice quite significant savings. So information sharing, I think, again, trying to get physicians and the teams more alert. There's a lot of miscommunications at all levels. So the hospital, the doctors, no one knows what's going on. And every meeting, if you bring a doctor, he'll be complaining about this electronic worker doesn't work, I can't get my CPT codes, we can't. So what we try to do is really design models and workflows that are integrated into what they're doing. So the doctor is there providing services to the patient, but people work around him. We created a virtual world around him. The care managers and our PHNs can help and really take care of all those. You know, they can go out and get stool samples for colorectal. They can get urine samples for chlamydia screenings to meet our quality metrics. Doctor doesn't need to do that stuff. You know, so that's one of the areas that we kind of focus on these team meetings. Now, go back. One of the platforms that we use, so Community Computers is the MedDen system, and my belief is probably the best electronic record that's out there. I've been using it for about 22 years. And this thing can school Cerna, school Epic, I know them all, NextGen. I can tell you when you go into those systems, stuff doesn't work. You know, and it was put together by the data analysis, somebody that does data, not doctors. I need something that's gonna help my people do their work. So what we do is, with the system, I get each practice that has it, and we bought some EMRs for practices that didn't have it. In order to do that, they can actually look at dashboards. So you know exactly what your trends are. If you have your markers, so our breast cancer screening rates, we're gonna be 69%. You know, you can tell that we're hitting those numbers, and that can happen. This is real time. This is happening today, this month, not next month. And if every practice is doing that, then it becomes a lot easier. And we can click on this and go to the provider level. And you can click on it and you go right to the patient level. All very quickly, very fast. And we've also put flow sheets. So if you're in here or if you're in a chronic disease and you're seeing hypertension, it maps out all the GFRs. So now you've got a hypertensive with an echo that showed LVH, that has renal. That changes the whole picture of who that patient is and how you manage that patient. And so this is what this level of information was real important in order for us to kind of show the docs. And they feel more engaged. You know, one thing about docs is, if I have a doc that's scoring 95 and I got a doc that's scoring 65, in about 2 months, they're both 65. Doctors don't like to, know that other people are outperforming them. So if you're showing them and you show them how everybody else is doing, they actually do a pretty good job. So we use 3 platforms for the informatics. And the reason is, so Tableau is really nice. It's eye candy. You know, doctors can look at eye candy and really learn a lot. Now, Clinigence, it's a little more involved, and Clinigence for us was more an aggregator product. So our care coordinators, if they're out in the field, they can actually input data. So if they went to a site that doesn't have electronic records, they can just import the sites. But Clinigence also, if they're on platforms like Allscripts and MedDen, we can pull that data out at these sites, and this happens every night.
Just to be clear, is this software that your group has created from scratch?
Some of it, no. Some of it we actually partner, and so we partner, but
these were not existing products.
No.
That you went out to the market to find. You hired a software group to write this for you, basically.
a little bit of both, yeah. We played with it ourselves. We built our own clouds because we found, as a doctor, I don't have IT background, but I found that this is not that complicated after a while. The box is not that scary at all. You have no idea where I live now because I
teach computer science for a living. Try it.
So let me tell you. So I'll tell you the informatics. I built a Microsoft backbone, and so I use remote terminal servers. I use SharePoint. I use Skype. I networked the whole thing, but we tied it into a lot of the BI and analytics to be able to learn. And back in 1996, that's when I first started using computers. And I did because I went we had a computer city. There was a 16-year-old kid there that knew everything. I had no idea what he was talking about, but I knew that I needed to learn fast. So that's what we did with the docs, to try to get them along that area. But Clinigence allows us to really map out the gaps in care, but it also helps us kind of pull data from the real. And what we do for the managed care companies is we're able to inject the deficiencies that they have. So now, I'm a 360 view, they're only a 180 view. But we can give them the 180 because we have patient-reported data. We have other stuff from the real. We have things that are in our EMR. Blood pressures, we can now create HEDIS numbers for them and be able to transmit the data back to them. So it's beneficial in that sense. Now, the qual metrics, this is the key. So this is the one we use at the ACO level, and I'll show you why we use that at that level. But the Tableau, it's nice. So this is our measure for January of this year. You notice that green, blue is where we have to be. Some areas are really close. And so, but you notice blood pressure, right? No results. And what we're doing right now is mapping out those HEDIS CPT codes and transmitting it back to them, so we're able to get our numbers back up here. But our margins are really close. And now we go to our teams. Like my biggest deficiencies are the 2 hospitals. So now I've got to go out there and try to figure out. But one of the things I told them is, we're in the pilot now, so if you can't comply, you're gone. So they've never heard that before. And I think they understand, and I think we're going to stimulate them to kind of get to the quality metrics. Because as a hospital, you don't want to be lower than your primary care doctors outside. And I think right now, we're the ones carrying most of these quality metrics. Clinigence, again, enhance the gaps in care, which is kind of cool. In terms of getting the QMX tool. So this is the one we use at the ACO level. And what it does is, it takes your contract, it dissects it out, and it gives me a whole lot of good stuff. It's got 3M capabilities for risk scoring. It's got New York diversion guidelines. It's got as much stuff as you want in this thing. So you can look at this as the doctors, and we see we have about 1.2 and $1.3 million super users and avoidable ERs. And when we click on that, we go right to the source, we go right to the doctor, we go right to the patient, we go right to the hospital. Okay? And that becomes pretty easy. One of the things that we found with value-based that was interesting is, as I'm looking at the data, for this month, we had 2 patients that were outliners. So I'm looking at the data. We had normal vaginal delivery, no complications, that cost me $52,000. I had a inguinal hernia with no complications that cost me $50,000. Wait a minute. So that gives me an idea to go back to some of my partners and say, wait a minute, this number's a little way. So we can't adjust your contract because it was set before I could play. But now I want rebates. So you better give me some rebates. Because that's it. But these are not ways that doctors offer. We never think this way. We're always kind of doing other things. But now that'll help us kind of equate that. So we kind of learn a lot about the data. This is another side. So the big buckets that we deal with are, and you're going to see a lot of inpatient, outpatient, and professional services. So if we do a good job, I don't care about professional services. I want more primary care visits. I want to see more costs going in that direction. But my inpatient and outpatient, this is where we're going to start to drill down. And so I find that the hospital clinics like to admit people. They pay their doctors. We were talking about a primary care doctor that they're willing to pay more for. So they'll pay that primary care doctor a lot of money because they want more referrals. That's not how we operate. On the outside, that costs us money. So we're going to teach them that if you want to continue to admit, we're going to go back to rebates. And they're going to have to rebate me some of that stuff. So you admit as much as you want. But this is all I'm willing to pay this coming year because I'm on the hook for those dollars. So that's one thing. The other thing is you start to kind of develop quality reports among all the providers. See where everybody kind of falls in that ranking. In addition to that, we got scorecards on them. So this is my scorecard. Now, I don't see a lot of patients anymore. I've got 10 providers, so I try to, it's something I feel my talents are better used for population management, so I can touch more people than just one at a time. But you start to get into the areas of cost, quality, and prevention, and then you start to see how one doctor does compared to another. And I think this is what's coming down the pipe. You will have scorecards on people. Now, we also have scorecards on specialists. And what happens here with the specialists is, if you notice, most specialists are coding chest pain, essential hypertension, all these non-specific CPT codes. They're all non-specific. So what we do is we teach them to get up here, to get to the right codes. If you had a patient with essential hypertension for 5 or 6 years, they should have had an echo. It's a cost you want to pay for, because you're going to find that they had hypertensive heart disease. And in some cases, what I find too is I get people that have had hypertension for 5-10 years, now come in, they're depressed. They don't feel too good, And when I do an echo, I find that the depression is coming from heart failure. Ejection fraction of 10%. We never aggressively manage these people. So this is how this data is going to become quite important, but you begin to understand where the specialists, where your radiologists are, where our trends are coming, if they're getting better or not. And so the metrics are real important. But like I said, these are the 5 buckets that if you're involved in value-based, these are the areas that you're gonna need to kind of do some homework on. Ancillary services, interesting enough, you gotta watch that. Because people get crazy. Some of these home health agencies order a lot of stuff that doesn't need to be ordered. And as doctors, we weren't paying attention, but you know, you should have just 1 hospital bed, not 2 or 3 a year. And so when you start to, that's some of the stuff that you'll be seeing when you analyze the data. I think for us, the secret sauce was really the health home. And I think GBON, because of that care coordination and being able to take some of those high-cost individuals, transfer them into the health home and get them into these primary care offices and manage them differently. So with diabetes, we're more aggressive. We're teaching primary care to become a little more aggressive with diabetes. Don't just put people on 1 or 2 pills and not follow up. If their hemoglobin A1Cs are over 10, you know, insulin is not a bad thing to put on some of these individuals to get them where you need to. You avoid the complications. On some of the preventive stuff, if you send a diabetic for eye exam, may not go to see the eye exam. But if you have a retinal screener in your office, it takes 2 minutes. Anybody else can do it, one of the navigators. And I tell you that you have some possible bleeds in the back of your eye, you're gonna follow up and get the treatment you need, but at least we know that that's what's going on. But the care coordination, if you don't have a case management team and an IT backbone, don't get into value-based. Because that's how you're gonna really make a difference. Otherwise, it's gonna be very difficult for you to kind of survive. Pharmacy is another area. We found that in our model, if we switch 6 drugs from trade to generic, 6 drugs saved us $3.5 million out of our $16 million budget. That's it. And it wasn't, you know, it was sort of going from drugs that were not that much different. So this area here, we work with managed care, their MDM, ways to kind of really look at how the substitutions make sense. If a patient's on the right drug, we don't touch them. But in some cases, it's not a bad concept to kind of go with. So the low performance, when we put our outreach together, is how do we get people to do what they need to do? So I've always, in this market, felt we need to incentivize people. So what I did, so we incentivize. If there were low performance, if you needed a mammogram, we gave you $25 when you got it done. If you went for a colonoscopy, we gave you $25. If you got an eye retinal exam, we give you $25. The sweet spot is $125 to $150. The state doesn't want you going over that. If you do, then you got issues. But at this point, it worked. People, little incentives like that do carry a lot of weight. The other side of it was just using automated systems. We put our contact system together. So now we have almost an AI built-in model to be able to give you that sort of American Express call-in, you know. You know, so it's linking you to the right people and actually using 2-on-1 data. So I don't know how many of you guys understood the 2-on-1 data, but 2-on-1 is really great in terms of social determinants of health, and the dashboards in Buffalo really help. We actually scrape their data and we actually close out. So when there's something open on their end, we make sure that that patient went for the referrals or services. And at the same time, after hours, if there's 2-on-1 need, we actually pay them to kind of handle those costs for us. Risk scores. This is where it all lies too, is really teaching doctors how to code correctly. And I think a lot of us tend to code and we don't, you know, put the right things in there or use a term, you know. Risk scores are, for example, in a diabetic, and I'm going by old ICD-9 codes. If you have a simple diabetic, the PMPM on a 250.02 is $800 PMPM for that individual. If that individual has renal, okay, chronic kidney disease level 3, he's a different diabetic. That coding of 250.42 is $27,000 in a PMPM model. So, you know, they have to see that we're managing patients that have the right coding, because they're going to require more resources. And I think in the value-based budgets, we're not seeing that. We're not seeing that. So what happened with us was we looked at last year's claims data, and what we were doing is comparing different things. So what they found was we do about 30% Your Care's book of business. It's about, we're managing $51 million in our value base. But what we found was that the individuals that were in our value base compared to the general population, we had higher risk scores, almost 2 points above the risk scores, but the budget didn't change. So that was one thing. We also found that patients that were in a health home, especially our health home, were lower costs that weren't in health homes. So, you know, you start after a while to look at the data and it starts to make sense that we're actually saving dollars